We have already seen alpha blockers. Now let's learn about beta blockers. Today we will be learning their definition, mechanism of action, classification, systemic effects, clinical uses, dosage, adverse effects, and contraindications.
Your body naturally produces agonists, like adrenaline. These agonists seek out beta-adrenergic receptors. They bind to them to trigger a physical response. Beta blockers fight against these natural agonists. They compete to occupy the exact same receptor site. Think of this as a lock and key mechanism. The beta receptor is the lock. The medication is a false key. The beta blocker molecule physically occupies the receptor. It acts as a shield. It binds to the receptor, but it lacks the exact shape to activate it. It simply sits there. This prevents the natural agonist from binding. Propranolol is our prototype drug. It sets the baseline standard for this entire class. This simple cellular mechanism triggers profound systemic effects. We call this hemodynamic modulation. In the heart, the drug decreases the heart rate. It softens the force of contraction. It lowers overall cardiac output. It also slows electrical conduction. This greatly reduces the heart's workload and its demand for oxygen. This is vital for patients suffering from angina. In the blood vessels, a fascinating two-phase reaction occurs. When first used, peripheral resistance actually increases. However, with prolonged use, the blood vessels adapt. The resistance falls. Blood pressure gradually decreases. That exact same mechanism causes diverse effects across the entire body. In the respiratory tract, blocking these receptors increases bronchial resistance. For healthy individuals, this is minor. For asthmatics, it can cause life-threatening bronchospasms. There are also metabolic effects. The medication delays recovery from low blood sugar. It also hides the warning signs of that low blood sugar. In the eyes, topical application effectively lowers pressure. Finally, in skeletal muscle, it can inhibit tremors. However, it may reduce overall exercise capacity. With that cellular foundation laid, we most organize these powerful medications. We classify them into their evolutionary and functional families. This taxonomy provides a logical structure for your clinical choices. The development of these drugs occurred in 3 distinct generations. Generation 1 includes older, non-selective agents. They are blunt instruments. They block receptors broadly across the whole body. Generation 2 introduces agents that are highly specific to the heart. Generation 3 brings advanced capabilities. These include vasodilating and alpha-blocking agents. Each generation represents a deliberate evolution in safety and precision. Mnemonic devices are incredibly helpful to anchor these classifications. For non-selective agents, remember this phrase: non-cardiac people prefer large cars. This recalls propranolol, pindolol, labetalol, and carvedilol. These drugs block both beta-1 and beta-2 receptors. For cardioselective agents, remember this phrase: my angry aunt bought 8 big cute necklaces. This targets beta-1 receptors. It helps you recall metoprolol, atenolol, esmolol, and bisoprolol. The second generation demonstrates the immense power of specificity. These cardioselective drugs preferentially target beta-1 receptors located in the heart. Crucially, they mostly avoid the beta-2 receptors in the lungs. Metoprolol is the standard prototype here. Atenolol provides a long-acting option. Esmolol is ultra-short-acting. It is delivered intravenously for emergency arrhythmia control. Nebivolol is unique. It enhances nitric oxide production to cause vasodilation. This specific focus makes these agents much safer for patients with asthma. The third generation offers unique dual-action agents. Drugs like labetalol and carvedilol block multiple receptor types simultaneously. Labetalol blocks beta-1, beta-2, and alpha-1 receptors. This makes it a primary tool for hypertensive emergencies. Carvedilol blocks those same receptors. However, it adds calcium channel blockade and antioxidant properties. This creates a distinct hemodynamic profile. It makes carvedilol exceptionally effective at protecting the heart in chronic heart failure. Beyond receptor selectivity, we must understand how these drugs travel through the body. This is their pharmacokinetic trajectory. Lipophilic drugs, like propranolol, are fat-soluble. The brain is rich in lipids. Therefore, these drugs easily cross the blood-brain barrier. This creates a much higher risk of neurological side effects. Conversely, hydrophilic drugs, like atenolol, are water-soluble. They do not easily penetrate the brain. They rarely cause neurological side effects. They are safely cleared by the kidneys. Translating this arsenal into daily practice requires extreme precision. There are vast differences in potency across this drug class. A standard daily dose of metoprolol can range safely up to 400 milligrams. Conversely, a highly potent drug like bisoprolol requires a fraction of that amount. Its dose might be just 2.5 milligrams. Nebivolol is typically administered at just 5 milligrams once daily. Carvedilol must be started at a remarkably low dose of roughly 3 milligrams for heart failure patients. Extreme precision in dosing is an absolute requirement. Because the receptors are widespread, the clinical applications are vast. A helpful memory aid is "healthy arteries mean active cardiac goodness mate." This phrase covers hypertension, angina pectoris, myocardial infarction, arrhythmia, congestive heart failure, glaucoma, and migraine. Systemic tolerability requires constant monitoring. A simple phrase recalls the distinct adverse effects. Beta blockers can tire guys, causing impotence. This reminds us to watch for bradycardia, cold extremities, tiredness, gastrointestinal upset, central nervous system effects, and impotence. Central nervous system disruptions are highly impactful to a patient's life. These include vivid nightmares, depression, or forgetfulness. Vigilance is required regarding critical drug interactions. The interaction with anti-diabetic drugs is especially dangerous. Beta blockers inhibit the liver's ability to release glucose. This lethally delays a patient's recovery from low blood sugar. Even worse, the medication masks the body's critical warning signs. It hides the rapid heart rate and tremors that alert a diabetic patient that their blood sugar is crashing. You must also monitor combinations with digitalis. This causes additive depression of the heart's electrical nodes. There are absolute clinical boundaries. These are specific patient conditions where these drugs are strictly prohibited. The mnemonic is breathing can hurt very dangerously, withdraw. Breathing reminds us of bronchial asthma. Severe bronchoconstriction can occur here. CAN stands for COPD. HURT stands for heart block or sick sinus syndrome. VARY is for variant angina. Dangerously stands for decompensated heart failure. And withdraw is a critical rule. You must strictly avoid abrupt withdrawal.